All right. So to be cognizant of everybody's time, I want to welcome you to our first webinar of 2025. We're very excited to present to you today on all sorts of good stuff. We're certainly going to go over maternal levels of care, but we also have some announcements from the Michigan Hospital Association and the Michigan Department of Health and Human Services. So to start things off, since we have quite a full agenda, I'm going to turn it over to Dominique. And she's going to talk to you today about a couple of things that from the Division of Maternal and Infant Health that all of our hospitals will want to know. So thank you for being here, and I'll hand it over to you, Dominique.
Thank you, Madonna, and thank you guys for joining this afternoon. Like Madonna said, I'm Dominique Abram. I'm with the Michigan Department of Health and Human Services, the Division of Maternal and Infant Health. And we are really excited to be letting you guys know that we will be able to support the maternal health quality payments again in September of 2025 to birthing hospitals that are fully participating in MyAIM and that have submitted applications and or have already applied for the Joint Commission's maternal levels of care verification program. So the memo that's scrolling on your screen, you guys can see that the top section is for birthing hospitals that have already applied and that signed up to participate for maternal levels of care verification in 2024. And then the second half of that, and I'll go over that information with you guys too, is for those who didn't get a chance to apply in 2024 and are interested in applying in 2025. So to receive those quality payments for 2025, birthing hospitals must meet these requirements by July 31st of 2025. So that was the cutoff last year. We ended right at the end of July, and then the birthing hospitals will receive their quality payments. The date varies, but it's usually in that first week of September. The payments will go out. So the payment amounts are the same for the birthing hospitals that they were in 2024. So if you participated last year, the amount that your hospital received will be the same for 2025. If you didn't participate last year and you want to know what your hospital's amount will be, my email is at the bottom of that memo. You guys can email me and just let me know what facility you're representing, and I can tell you what your amount would be for your specific facility. A couple of things to note: the quality payment follows the same pathway as your Medicaid reimbursements. So, however that money reaches your facility is the same way that the quality payment would reach your facility. And then one thing that we did last year, and we'll do that again in 2025, is earmark those funds to make sure that they get to the labor and delivery units that they're destined to go to. We heard a lot of feedback that I'm sorry. Oh, I thought maybe somebody was talking to me. Sorry. We heard a lot of feedback in 2024 that, work is being done and sometimes the departments never see those funds. And so we wanted to do our best to try to make sure that it was clear where that money was supposed to go. And as far as I know, that went well in 2024. So we'll do that again in 2025. Sorry. So for just a quick overview, for the hospitals that did participate in maternal levels of care verification in 2024, we will need a renewed commitment for 25 for MyAIM. They have Laura Holdishall's email on the memo, but I think we are actually asking to send communication to the MHA Keystone contact, because I think that Laura Holdishall is probably going to be out for a little bit. We also asked, one of the other requirements is full participation in MyAIM. So that includes submitting data for at least one of the safety bundles, either hypertension, hemorrhage, or sepsis. And then if you applied in 2024, you should be having your Joint Commission on-site visit no more than 1 year from the date that you submitted your application. So depending on when your facility submitted your application, will tell you when your 1 year mark is. But you should have your Joint Commission visit no later than that date. And then, excuse me, for those that did not apply in 24 and are seeking maternal levels of care verification in 25, same rules apply. You'll need your MyAIM commitments and submitting data for at least one of the My Aim safety bundles. And then you will determine what your level of care is going to be. So your internal teams can decide where you feel like you qualify. And then you will submit an application for your verification program. So you don't have to have your Joint Commission visits this year if you're applying for the first time, but you will have to have your visit within 1 year of your application date. So if you haven't applied yet and you plan on applying, the same rules for the 2024 facilities, you guys will have 1 year to get your visit completed by the Joint Commission. And you can invite the Joint Commission whenever you want. So they're open. It's not a surprise visit. It's not punitive. They really want to come in when you feel like your facility is ready and do the visit at that time. So that's for you guys to decide. And then down at the bottom of the memo, it's just the MHA maternal levels of care toolkit. So if you have specific questions or you just want a little bit more information, you can go to the toolkit. And then also I have my email and my colleague Megan. If you have specific questions about your facility or how much your quality payment would be, if you're participating this year, you can email either one of us and we can get you that information.
Thank you so much, Dominique. We do have a chat or question related to enrollment form, so I will let Naomi answer. If we have already submitted My Aim commitment agreement form to Laura, do we need to resubmit to the MHA Keystone Center?
The commitment forms are for annual renewal. So if you did a 2024 form, you still need to do a 2025 commitment form.
Yeah, so, and also if you did submit your form to Laura, unless it was submitted in the past like couple days, we do have everything like on our end. But if you are submitting new forms, we do ask that you please submit it to keystone@mha.org so that we have the current like list of who has submitted.
Thank you guys. I'm going to turn it over to Dr. Jones to share some more information.
Thank you, Dominique. And actually, I just have a couple slides additional to share with you all related to some of the support that the MHA is being provided through the support of the state related to maternal levels of care. So just to continue with the discussion, I wanted to first and foremost congratulate the 53 hospitals that did apply in 2024. Many of you that have been part of that cohort or know that it's one of the largest number of hospitals in any state that applied for verification. And I know by now, since we're in January, we've had quite a few that actually have gone through the verification process and have officially verified. So I wanted to just give a huge kudos to your team. I know a lot of preparation and work went into that process, but the good feedback is for those that may not applied. It seems overwhelming at first, but it's really, really a smoother process than it does look on paper. And some of the tools that we are so happy to be able to provide you through the support of the state again help walk you through that process. So again, all of the information that was shared with you today, available not only on the MDHH website, but through that memo, but also our website that outlines the cost requirements and what is being covered, as well as the MHA toolkit that we'll share with you in a second. And we realize that many of you here are joining from the My Aim Collaborative and may have more of a clinical role. So we are hosting a informational call that we are making available to any staff within your hospital that may partake in needing to know this information to join us February 6th. The information about that call did go out in individual hospital emails that were sent on Friday from Amy Brown that included contacts like the primary My Aim contacts, your CNOs, and your MLC contacts communicating your current status. So again, many of you should have your hospital should have received like where are you at in meeting your My Aim enrollment for 2025, as well as your verified maternal levels of care application status. And so registration link is here. We will also put it in the chat box while Dr. Jones is sharing the good information about why we're pursuing maternal levels of care here in Michigan. So please be sure to register if you haven't already done so. As again, to reiterate, the cost associated with being verified through the Joint Commission is being covered directly through the MHA Keystone Center through funding support from the state. And so we have worked with the Joint Commission team to directly be able to cover those costs so that you're not being reimbursed. We directly cover those costs on behalf of your hospital once you have gone through that application process. Unfortunately, the invoices still show up within your hospital Joint Commission portal, but please disregard, and we have information that shows exactly what that process is. It's called the TJC MLC cost flyer. So just kind of outlines, what the cost is, what is being covered, and it's a good tool for you to share with maybe a Joint Commission portal user or a finance individual to kind of alert them to say, FYI, don't pay for these invoices. MHA is being covering those costs directly through that funding from MDHHS. And so in addition to the cost coverage, we are also offering support for those that will be pursuing verification. So if you're in cohort 1, which is those hospitals that applied in 2024, you've been part of ongoing what we refer to office hours. They are bi-monthly. Actually, our last call will be in March. And they continue to allow you the opportunity to talk with one another, to share tips and strategies, and walk through that process of verification, both the application, but now, of course, for those that cohort that went through in 2024, more about the process of preparing for that on-site visit so that you are prepared and have a successful verification. For those that will be, well, we hope, will be pursuing Joint Commission verification in 2025, we do intend to also have office hours dedicated for your cohort, where we will kind of go back to that application process and make sure that you're prepared and walk you through that process from the get-go. The time and date and schedule will be determined based on the feedback of those that will be pursuing MLC in 2025. So be sure to join the February 6th call where we will share more information. And again, lastly, before I kick it off to Dr. Jones, a reminder about the MLC Toolkit. It has a lot of great information to walk you through, including a step-by-step guide. Where do you start? What's step 1 in that verification process? And what team staff members do you need to assemble? And just a lot of great resources that also come from our now hospitals in Michigan who have gone through that process and developed their own resources. So thank you to those who have gone through that process and kind of laid down the groundwork for us to learn from you as well. So thank you for your time. We are here to support you. Again, the toolkit, I am here in case you have any questions. So feel free to contact myself as the MLC point of contact at the MHA. And now, unless there's any questions specific to that, I will kick it off to Dr. Jones to talk about why maternal levels of care.
Good afternoon, everyone. I hope you can hear me okay. I'm going to start screen sharing, and hopefully you can see that all right. Is that a yes or no?
Yes, we can see it.
Yep, we can see you now.
Okay, perfect. So, as I said, welcome. I am the past operations co-chair with Madonna, and I am now working alongside Dawn Schonefeld, who is the executive co-chair, and we are part of Michigan AIM. We've been talking about maternal levels of care probably since 2021. Many of you may have remembered a webinar when we had Dr. Chris on from ACOG talking about this program as it was going to be rolled out, excuse me, into 2022. So hopefully this will solidify and help provide some additional information and transparency about the need to move forward. So here are just some basic objectives, and it's really to talk about how the obstetric facilities can prepare to provide risk-appropriate care, and by doing so, then decreases severe maternal morbidity and mortality. Understanding and explaining the levels of maternal care designation and how they are embedded into all of the AIM bundles. And that will decrease health disparities and improve outcomes for some of our most at-risk populations. And then lastly, to describe the levels of care verification program briefly. I'll try to move this along, so we'll leave time for questions at the end. I have no disclosures. Just to provide a reminder of what the contact is for Keystone at MHA.org. And to give you an update, there's been some advancements and some changes in the organization at MHA, and we are so lucky to welcome Naomi, Allison, and Eva to our team in 2024, and now they will continue in 2025. Andrew Cyrek will be continuing to be oversight, and I know he's on the call today, but will continue in some different capacities. So we also will be adding a gentleman by the name of Joshua Squire, and he will take over the lead for the Keystone monthly My AIM leadership calls, and he will coordinate activities and ensuring the contract deliverables that are met for My AIM, as well as the collaborative work toward our collective goals with birth hospitals in Michigan. And I know Naomi's on the call. You can say, hi, Naomi. You gave us a nice update, and she will be leading the quality improvement efforts with the birthing hospital. So you'll be working with her often, and she'll be providing the dedicated support, one-on-one technical assistance for virtual meetings, on-site visits, and she will support all of the birthing hospitals with the patient safety bundles and maternal levels of care implementation. And last but certainly not least, Allison Bertume, I believe I pronounced that correctly. Correct me if I didn't, Allison, will lead the data collection team and reporting processes to monitor the progress collaboratively. As we know, My AIM is data-driven, so this collaborative will not be able to succeed without having the data. So this is such an important part of the work. She is available as a subject matter expert to help birthing hospitals analyze their organizational performances and assist in providing innovative actions to further drive improvements. And as we mentioned, Laura Hodeshell is on maternity leave for several months. If you've sent her a message and haven't gotten a return in a few days, just go ahead and shoot it over to Keystone at MHA.org. So on to the maternal levels of care. When we look at the AIM bundles, you can see in both hemorrhage and hypertension that all of the bundles comment and have places for escalation of care, whether it's in readiness or in response. So maternal levels of care naturally aligns with the AIM bundles because it's the process to escalate care, whether it's necessarily in your hospital to where the next step would be outside of your hospital. And just a reminder, we have seen amazing outcomes since the start of My AIM. When I joined the collaborative in 2015, hemorrhage was a primary cause of maternal deaths in Michigan. And the good news is by reducing the hemorrhage, severe maternal morbidity and improving that by almost 50%, we no longer have hemorrhage as the leading cause of maternal deaths. That's the good news. The unfortunate news is sepsis has taken over that role, but we are now rolling out the sepsis bundle. And again, that's why we chose it. You can also see that we've had some significant reductions in the improvements in the hypertensive disorders of pregnancy, but there's a little more room to go, and we continue to push forward with our hypertensive bundle. But as we all know, that there are still gains to be made and that we still see at least a 3-to-1 ratio of worse outcomes for our Black birthing persons and our Indigenous birthing persons when we compare those to white birthing persons. And this is just overall severe maternal morbidity from AIM data. So what is the My AIM response? We know that the Michigan Health Equity Fund has a grant that was awarded to hospitals in the Metro Detroit area based on their severe maternal morbidity rate. their disparities in Black and white outcomes, the fact that they were participating in My AIM and had a sustainability program in place. We also have continued education and bundle implementation to support and address systemic racism, which we know drives some of these disparities. And we are now formalizing maternal levels of care into bundle implementation. And I hope I can make the case as to why this is a much needed and timely tool that we will be able to use across our hospital systems. So how can maternal levels of care impact systemic racism? It is a formalized process to escalate care. So it's not a decision by decision. It's a process that is in place based on a clinical circumstance. And so that does reduce implicit bias for the escalation of care. And as I mentioned, it is most impactful for conditions like hypertensive disorders of pregnancy and sepsis that our Black and Indigenous birthing persons are more at risk for. So in 2022, a statement about the strategies for implementation of maternal care on a national scale was released. And this document commented on the fact that high-risk pregnant persons should receive care in facilities that are prepared to handle the specialized care that their medical and obstetrical conditions may require, and that identifying these high-risk conditions and birthing persons in the antenatal or prenatal period could allow for a referral or a transport to a facility ahead of some type of event. And that could improve outcomes. And that successful implementation of having maternal levels of care had the potential to advance health equity. So what are maternal levels of care? It's essentially care in the right place, in the right time. And I think if you keep that in mind as a framework for this discussion, it helps make it a little more granular. And levels of care in medicine are nothing new. We're all familiar with neonatal, NICU levels of care, intensive care units, trauma center designations, post-acute care centers, stroke centers. And so levels of care is something that's very familiar to acute care and post-rehab care settings. In 2015, there was a consensus statement from ACOG and the Society for Maternal Fetal Medicine that I sometimes will refer to as SMFM, and ACOG as ACOG, about maternal levels of care. And the consensus statement was originally published in 2015 and then revised in 2019 and really emphasized a framework for regional hospital relationships and called hospitals to develop standardized descriptions of their capacities, resources, staff, and personnel that could handle obstetrical conditions and encourage the development of collaborative relationships in regions to ensure that services, if they needed to be escalated, there is a seamless process for consultation and transfer, hence the idea of care in the right place at the right time. And part of the reason this has evolved over time is because levels of care have been something that the CDC had offered as an elective or voluntary survey that you could take, the Locate tool. Many of you probably remember filling out those surveys, and it sort of self-designated what your level of maternal care would be. And in 2017, AIM went through a pilot program in several different states, and they used that information from the Locate tool and then went out to those sites that had used the tool and did surveys on site and found that probably 50% of the hospitals had over-designated, meaning given themselves a level higher than they actually met. And so as most of those errors were a higher level than indicated, it really called for a more standardized process. And so in 2019, levels of maternal care re-emphasized that level 3 and level 4 hospitals should support level 1 and level 2. And the other thing to emphasize is that the level of maternal care may not always match with the neonatal care. You may not have a NICU nursery in a hospital that's designated as a level 3, but that is something to be aware of, but it is not a requirement. And that each level of care does reflect the minimal required capabilities and physical facilities, as well as medical support and subspecialty support that is required, and that each higher level of care includes and builds on the lower levels. I think this next graphic will probably give you a little bit of a better idea. So level 1 all the way to level 4 being the highest level. There's basic care to stabilize, initiate management, and make the diagnosis and determine if a transfer is needed. Then going to a level 2, which would be moderate high-risk conditions, antepartum, intrapartum, postpartum, which includes all of level 1 plus that level 2. Level 3 now introduces subspecialty care for complex maternal conditions and obstetrical complications. And then finally, level 4 is essentially a regional perinatal care center that includes all of level 3, plus the most complex conditions for critically ill patients. So the goals of maternal care is to reduce the preventable maternal mortality and severe maternal morbidity by ensuring equitable and seamless access to high quality, risk appropriate maternity care. So it is not a care bundle, but it is a framework for the regionalization of that care and establishes that formal relationship prior to an event, that it's embedded in all of the AIM bundles as a process to escalate care. And again, care, if you think about it, care in the right place in the right time. So here's just a couple examples of what a potential level 1 obstetrical unit would be versus a level 4. So there would be limited OB ultrasound. There would be resources to initiate a massive transfusion protocol, and a seizure provider could be available, but possibly not on site. Level 2 would include all imaging services with interpretation on site available. Level 3 would include the ability to complete a massive transfusion protocol, have detailed obstetric imaging, other types of procedures that would include embolization for hemorrhage, stat teams, and ICU care. And then obviously level 4 would be the most complex patients. So looking at the Joint Commission and ACOG and SMFM developed the content for the maternal levels of care, but really did not, either one of those organizations, they're professional society organizations, they did not have the infrastructure to do site visits to provide this accreditation to the hospitals. So they partnered with the organization who is the leader in site visits and that we all know as the Joint Commission. And so they launched the program in 2022. So the Joint Commission really goes out to the sites to determine if the content and level of maternal care matches what the hospital is applying for accreditation. And it was launched, as I mentioned, in 2022. And it really aligns with the ACOG SMFM consensus statement on obstetric care. So the overview of the process. It is the ACOG SMFM care consensus. Each level must contain all of the elements preceding. That the hospital self-designation through the CDC toolkits tend to overestimate. That the Joint Commission then provides the on-site survey, which is the basis for the care level designation. And it's provided to acute care and critical access hospitals for a 3-year cycle. And as you heard earlier, the good news is funding is still available that is being run through MHA, but that funding is contingent upon participation in MyAIM and maternal levels of care in order to receive the Medicaid quality payments that Dominique was referencing earlier. So funding is still available to get certification through maternal levels of care through MHA, and you need that at least application process to be ongoing in order to receive 2025 Medicaid quality payments. So a little bit about the on-site process. I'm at Trinity in Ann Arbor. I heard when I was on call Sunday night that we have our site visit the first week of February. So our site survey will be coming soon, and I know it has taken a huge amount of work and effort, but I do want to say that all the hospitals that I've heard from, and in speaking with the leadership at the Joint Commission, they are really partnering with the hospitals. I want to emphasize that this is not punitive. This is a voluntary program, so they are really working alongside the hospitals to get them certified as quickly and easily as possible. But there does need to be on-site visitation, which will include the opening conference, a medical review, unit tours, and a closing conference. And much like I'm sure what other surveys you have on site, it's looking at compliance, policies and procedures, assessment of quality improvement, prudential reviews, ongoing education and evidence-based practices, and looking at, in the closing conference, a preliminary report as to which level of care the facility would meet, and if there are areas that still need work and opportunities for improvement. So at the post-survey process or closing conference, essentially, there will be a preliminary report issued, and then the Joint Commission will issue a final report. And at the time of that closing conference, if there are standards that haven't been met, the facility has the opportunity within 60 days to meet the evidence of standard compliance. And the Joint Commission will review that. If accepted, then the verification is granted for 3 years. And if that hospital is unable to meet those standards of compliance as the Joint Commission outlined, then that verification has not been completed and would need to be applied for in another cycle. As was mentioned, there are office hours coming up to talk about the maternal levels of care support, and that will be offered through MHA. I know the next one is February 6th, as was mentioned. And in that, we'll be talking more about the long-term sustainability of this program. We understand that right now there is funding for all of the hospitals who are applying presently to get their verification for that first 3-year cycle. And there's been some concern about what does that financial burden look like 3 years from now. So we're going to address some of those issues about the sustainability of this. And there's a link to the toolkit that has been very helpful to many sites. What I want to talk about next is what maternal levels of care, but this is from ACOG, and they haven't changed some of their slides yet. What maternal levels of care look like on a national level. And so the green states are those states that already have this in place. I will tell you that some states applying for maternal levels of care is a mandate. Currently in Michigan, it is a voluntary program. But for instance, in Texas, in order to receive Medicaid funds for births, you have to have your maternal levels of care designation. I also know that Florida is in the process of maternal levels of care, and that is also going to be, it's to be determined whether that's going to be a mandate or a voluntary program. But when we were looking at it across Michigan, we really felt that it would be best suited if the hospitals had the opportunity to choose their pathway. But I'm hoping I'm making the case, and you can see that this is a growing trend across the country. And ultimately, just like Michigan was one of the first AIM states, we are going to be the first state to probably have the most number of hospitals participating in maternal levels of care. Also, I want to mention that it is now a statute, House Bill 5172, was signed into law by Governor Whitmer on January 21st. And this is the bill that enshrines maternal levels of care into our maternal health program across the state. Again, this is a voluntary certification, but again, it is now an official formalized part of our maternal health program in Michigan. So we've left some time for questions, and I'll throw up my email if you want to target me directly, but we'll look through the chat and take it from there. I'll stop screen sharing if everybody's got my email. So if anyone has some specific questions, please type them in the chat so we don't have 80 people trying to talk over each other. And I'll look for that. Dominique, Eva, Naomi, any other comments, questions?
Thank you, Dr. Jones. I'm monitoring the chat there. I don't see any questions in the chat box.
Nothing for me, but I'll drop my email in the chat as well if anybody has questions directly related to their quality payment for their facility.
I think for those that
from my end, I'm just gonna
go ahead.
I was just gonna say it one more time that please just, if you haven't submitted your MIAM commitment forms, to please submit those. We do have a deadline of January 31st. I have placed the information in the chat as well. I know that there are some issues also right now going on with the MIAM website, so we do apologize for those. But if you do run into those issues and you can't view the commitment form or the designation criteria, please email keystone@mha.org and we will get that information over to you.
I do see a question in the chat about what are the most crucial requirements for maternal levels of care. I don't necessarily think that the requirements are weighted, meaning that it's sort of an all or none. You either meet those requirements or you don't. And that was part of like the structure survey and some of the initial intake. Naomi, Eva, do you have any other comments on that? I know that the education piece is really essential, and much like when we have a Joint Commission visit, policies and procedures, education that's in place, having documentation of how that is done.
Yeah, so Dr. Jones, I'm going to actually attach to the chat, hopefully it comes through a quick start checklist that kind of goes through step in terms of what are the critical steps as part of the MLC application process. And that really is a great tool for you to kind of use to help understand both like the process of application, what information you need prior to application, because I think this is an important part of it, is at that point when you're applying, you will be selecting at which level you will be applying. And so as part of that process, you would have need to kind of do the work and working with your team to look at the standards. Again, basic 1, 2, 3, and 4, because there's 4 different levels, and make sure that you know where your hospital is at. So it's kind of like an environmental scan of your current services and practices to help you understand better, at what level do you feel you are at so that you can apply. And again, this quick start checklist that I'm going to attach walks you through that process, and it's available on our toolkit website. So I'm going to share that link now. And it's under the Joint Commission Maternal Levels of Care Overview tab. It's called Program Quick Guide Checklist.
Thank you, Eva.
My pleasure. And this is the beauty of the office hours. We had the great support from the Joint Commission team who joined the office hours. And so this is the type of information that would be also available in some historical recordings and resources that we have to kind of walk you through, like what needs to be done prior to application, what needs to be done after the application, and as you're preparing for that verification on-site visit. I think I'll say this based on going through this process with our hospitals. I am not an expert, and I just want to preface by saying that we leave this expertise to the Joint Commission team. This is truly meant to be a quality improvement opportunity that you work with Joint Commission on. It is not a way to penalize you. It is truly as a way, it's a process. The program is designed to help you kind of understand and better work within your services and capabilities that you have, but as well as regionally with your partners. And so I know some of the great feedback we received from, for example, for hospitals that just recently went through the verification visit with the Joint Commission, they found it instrumentally helpful to even work with that individual that comes on site to verify them, because they offer you suggestions and best practice tips. So it really is meant to be seen as a quality improvement evaluation process. But knowing where you're at is, of course, is important. So you should absolutely be applying at the level that you are at and not at the level that you may want to be. So that's another discussion for your team as well.
Well, thank you, everybody. I'll kick it back to Madonna. Anything from my AIM operations that you need to mention or?
Just reminding everybody, of course, about the commitment survey. Also, the structure survey will be coming out shortly. And our next webinar will be February 25th, same time, 4 p.m., where we will have a panel discussion around our hypertension bundle. We know a lot of changes in 2024 led to some anxiety and increased questions on how to follow up with our patients who have hypertensive disorders of pregnancy. So we're hoping to add to some of the success and growth of that bundle on the webinar for next month. So join us for that. And as always, please let us know if you have any questions or concerns that we can answer. Andrea from I think from Henry Ford is asking for clarification. If you submitted the commitment document to Laura or already by the December due date, I don't believe you have to submit it again. That is my understanding. So you should be good to go. All right. I think that's all for us. Happy to hand you all back about 15 minutes of time today. Thank you for attending. We look forward to seeing you throughout the year. Happy 2025. And we'll see you all soon. Thank you. Thank you.